Thank you for joining us today. All right, well, we're going to get started. You will see me just posting in the chat. That's just because we have some people joining in a little later. So we want to make sure to get them on the right channels. But we will get started with this presentation. Okay. All right, perfect. So, good afternoon, everyone. Thank you for tuning in via Zoom for today's Lunch and Learn session. We are hoping to have these quarterly, so keep a lookout for the next invite. We truly appreciate your time and interest in joining us as we explore the critical role of Central Health's medical respite program in our community. Before we dive in, I do want to take a moment to recognize the incredible work being done by our speakers today. We're fortunate enough to have with us two very outstanding leaders who are at the forefront of this essential program. First, I'd like to introduce Dr. Audrey Kwong, who has recently been named, in the last couple of years, Humanitarian of the Year by the Travis County Medical Society. Yes, I was going to bring it up again because it's amazing, for her extraordinary commitment to improving healthcare for underserved populations. Dr. Kwong's leadership and vision have been instrumental in shaping the medical respite program, ensuring that some of our most vulnerable neighbors receive the care and support they need. Joining Dr. Kwong is Laura Malone, our dedicated medical respite nurse manager. Laura brings a wealth of experience and a deep passion for patient care, making her an invaluable member of our team. She works tirelessly to coordinate care and provide a safe, healing environment for those transitioning from the hospitals. Together, Dr. Kwong and Laura will provide us with an in-depth look at how medical respite program is making a difference in the lives of individuals who need it most. I have mentioned a couple of housekeeping items already, but I'm going to repeat them just one more time to ensure everyone has an equitable experience during this English Spanish presentation. We are conducting it in both of these languages. If you are still on the main channel, the regular channel, please select the English presentation at the very top of your screen to view the presentation in English, or Spanish at the very top of your screen. This is the visual part. For auditory, even if you are an English speaker, please select the globe and select English for the English presentation, audio part, or Spanish. If you do not see the globe, you might need to press the three little dots and that say more. Esta presentación va a ser en inglés y en español. Por favor, seleccione en la pantalla arriba. Si quiere la presentación en español, seleccione Spanish Presentation. Si le gustaría ver la presentación en inglés, por favor, seleccione English Presentation arriba de sus pantallas. Y si le gustaría escuchar la presentación en inglés, por favor seleccione el globito abajo, seleccione inglés. Si le gustaría en español, por favor seleccione español. Si no ven el globito, van a ver los tres puntitos que dicen More. Seleccione eso, después el globo y después su lenguaje. Si tienen cualquier pregunta, por favor márquenme en el chat. Mi nombre es Yesenia Ramos. Pero esta presentación va a estar en YouTube. This presentation will be available on YouTube in both English and Spanish. So um, please let me know if you have any questions throughout. And thank you again for being here today. Now, without further ado, please join me in welcoming Dr. Audrey Kwong and Laura Malone.
Thank you so much for that warm introduction. We are so excited today to share with you about Central Health's medical respite program. It's something that I'm very passionate about and very excited that we have started this journey in Austin. So today we will be, let's see. Okay, here's our agenda. We would like to share a little bit about the background of our program and then bring you on a journey of how we have progressed over the last 2.5 years through our different phases, talk about criteria and how to make a referral, share with you a little bit about metrics of our program, and then end with a few patient stories, and then we'll open it up to questions. All right. So always want to start with the why. Why do we have medical respite in our community? And to get to that, I want to bring the voices from our community forward. As a provider serving on the front lines with our street medicine team and in our shelters, I heard very loud and clear from our patients so many different things, as well as voices from the Austin Homeless Advisory Council. And I'll never forget a quote that one of my patients told me, which is, I have nowhere to be healthy, I have nowhere to be sick. On top of that, people would tell me about how they were denied cataract surgery or orthopedic procedures because they were homeless. Some individuals weren't able to get chemo because they didn't have a home. And then many individuals weren't able to take care of their wounds when they were on the streets. In addition, we heard from our community health paramedics, our outreach workers, and our street medicine team how harrowing it was to find someone who needs shelter and who also needs medical care, but having no options for them. And then hearing from our hospital partners, some discharge planners and case managers would tell us just feeling very hopeless that they know a patient will be back when they have to discharge someone to the street, and how uncomfortable and terrible that feels. And so, with those voices, we really felt like we needed to bring this to our community, a medical respite program. And I just want to give you one more perspective. I worked as a hospitalist for many years, and I just wanted to share this perspective as well. So, if you're a patient and you get discharged from the hospital, if you look at the top panel, um, you go to the hospital, get care, and then you go home. And then at your home, you'll be able to get your medications, take meals, make phone calls if you have questions, schedule appointments, and do wound care if that's necessary. And then when it's time, you can get in your car and see your doctor. And so the healthcare system assumes that all of these things are in place for that very smooth transition. And then the bottom panel, compare that to someone who's experiencing homelessness. When they go to the hospital, they are discharged to the streets and they will not be able to take their meds. They will not have regular meals. They don't often have a phone to make follow-up calls, no place to do their dressing changes, no reliable transportation, and often no primary care physician provider. So you can see every red box is a barrier and a challenge to our patients who are experiencing homelessness. And you can see for that reason, studies have shown that individuals who are experiencing homelessness have a 50% readmission rate when they are discharged from the hospital. They stay in the hospital longer and they have higher costs associated with their care. So, with that, we wanted to bring medical respite to our community. And so the formal definition is that it is post-acute care for people experiencing homelessness who are too ill or frail to recover from an illness or injury on the streets, but not sick enough to be in the hospital. We also think of it as a short-term residential care for people experiencing homelessness that allows people to rest and recover in a safe environment, while also accessing clinical care and supportive services. At the end of the day, medical respite is really just a bed and shelter. And while that's something that I take for granted every day, it is something that is huge when you think about all the things that a bed affords you in terms of having a safe place to be, having a stable place to coordinate all your care. So, medical respite is really truly a bed and this wonderful team that is supporting you, helping you schedule appointments, helping you figure out what you want, what your next steps are, housing if that's something that you're interested in. So all of these things at the bottom, all these nifty icons I found, really think are other things you can do in respite, where it's wound care, taking care of your hygiene needs, regular meals, medications, having a place to rest, having appointments scheduled and being able to make it to them, a place for physical therapy, a place where we can coordinate your rides, and then just a place for social support, which is part of the healing process. So that's what medical respite is. And so let me take you on a journey of how we started. It's a very special journey because it's something when I moved to Austin, I felt we really needed, and many communities have it. And there were so many people interested that I talked to who really wanted to start a medical respite program in our community. I think one of the challenges was where are we going to have it, who's going to run it, and all these questions came up. And so as I talked about our program, I want to focus on four things. Where are the referrals coming from? Where are the locations? What does the team look like? And where what are the patients getting while they're with us, and what are the kinds of care that they get. So the first thing is referrals. So there's so much need in our community. As we started on this journey, we thought, okay, maybe the first step we'll take is taking patients from a skilled nursing facility. Those patients are coming from the hospital, going to a skilled nursing facility with many needs, and then ultimately having to be discharged off into the street. So this was our first opportunity to test our medical respite by taking patients from a skilled nursing facility. About 6 months later, we opened it up to, our partners, at Community Care, their healthcare for the homeless team, and those outreach workers finding patients on the streets who needed care. And then the following 6 months, we were able to start opening up to hospitals, and taking patients from there. And then most recently, we've been looking at taking patients from specialty clinics, patients who need procedures like a knee replacement, or patients who might need a colonoscopy. So those are where we're getting our referrals. In terms of location, I want to give a shout out to a new entry. This is where we first started our medical respite with 5 beds and quickly have added more. Um, a new entry is located in East Austin at 1808 Weberville Road. They are a residential treatment facility. And they have a lot of wonderful services there. The rooms are semi-private, so usually 2 to 3 to a room. And here we have currently 10 male beds and 3 female beds. So a total of 13 beds here. Our second location was Arch downtown, run by Urban Alchemy, and very thankful for that collaboration, able to provide us 10 medical cots on the second floor. For those who don't know, Arch is a shelter downtown that holds up to 130 people at night, located at 7th Street. It's a men's only shelter. And this was also a nice location to have for our patients who might need a more low barrier setting and might be a little bit more independent. Um, we since added 5 more beds at Marshalling Yard, about 5 beds, and that's another shelter in Austin as well. Oh, is this better? Well, I'll keep talking. All right, so I've talked about where our patients are coming from, the referrals. I've talked about a few locations, and now I would like to share with you a little bit about our team. We first started out with one social worker, Dustin, and then we added a nurse, our Laura here, and then we added a medical assistant. Then we've added another nurse, another medical assistant. I want to share that this team is so special. We come from various backgrounds. Some have worked in the hospital, some have worked on a street medicine team, wound care experience, hospice. But at the end of the day, this is a very passionate team that believes in whole person care. And so while someone may come with one particular illness, we're looking at the whole picture, and how we can really help this individual in addition, not only with their physical condition, with everything that they want to think about, whether it's social needs, housing, mental health needs, addiction. Issues that they're dealing with. We really think about whole person care. We really want it to be collaborative. We feel that a lot of times healthcare can be very prescriptive, can be fear based. We are deeply rooted in empathy and compassion and understanding what our patients have been through and really want to give them choice and really make it a collaborative journey for them. Lastly, I want to talk about clinical care. So, when we first started in our program with our social worker, we were really thinking about coordination of care, which is huge. There's so much to think about when it comes to medical needs in terms of appointments and transportation. But I'm excited to say that last year we were able to roll out a clinical component where we were able to start to do some vital signs like checking blood pressure, helping with medications, even some basic wound care. checking glucose. And this has been really great. As a provider, I know that medical care can be very rushed. We spend 20 to 30 minutes in an outpatient clinic, maybe a couple times a year, if, hopefully more. In the hospital, things are very rushed. Lots of people come talk to you, and it can be very chaotic and confusing. What I love about respite is that opportunity to just rest and really think about what's going on in your life, and that opportunity to sit down with a patient and really give them the time that they need to understand what's going on. And for the first time in a long time, maybe they finally have the bandwidth. Maybe their priorities are changing a little bit. And so it's such an opportunity to really intervene and give them the time to help them understand their health condition. So that was in September 2023, starting to add some medical things that we could do. And then this past summer, we were able to provide more clinical care at our Bridge Clinic, and really just bring more care into our program by bringing them to our clinic at Capitol Plaza. And patients loved, seeing us in our respite setting and then feeling the trust already, seeing us in this clinic. And all the things that are available at this beautiful clinic. The patient on the left was able to get an ultrasound the same day when he was complaining of some abdominal pain. We just walked him across the hall. He got an ultrasound. Our patient in the middle is meeting with our pharmacist on site. We have labs available. We have some specialists on site, again, pharmacy, behavioral health. So it's just a really wonderful clinic to really just wrap around care so that they're not having to go to like 3 or 4 different places. So that is the clinical care. And so now I'm going to turn it over to Laura, who is really the heart and soul of our program, to talk about how to make a referral.
Hello. Um, yeah, so the way that we have been creating referrals for and receiving referrals for medical respite is through REDCap. These are our criteria. So anybody coming to the program needs to be experiencing current unsheltered homelessness. Respite is a program for people who have an acute medical need that requires short-term care. So, a wound, a broken bone, they had a suspicious lesion, they had a polyp they needed to get assessed, they needed endoscopy, chemo, anything that kind of can be managed in a finite amount of time. They need to be consenting to come to respite, they need to want to come to respite. They need to be independent with their ADLs, that's their activities of daily living, dressing, bathing, feeding, eating, and mobilizing. They also need to be medically and psychiatrically stable. Our mental health professional is not available after 5 p.m. or on weekends, so we're not the most appropriate option for people who are managing an acute psychiatric crisis. And they also need to have MAP. So here's what our referral form looks like. It's called REDCap. Just has some basic demographic information. And then here's another snapshot of our criteria. They need to be all in the yes column to qualify for the program. Some of the things that I just mentioned, and they also need to be continent and alert and oriented. Right now, we're not equipped staff wise to manage things like dementia. So they have to be able to communicate about what they need. Here's just some another snapshot of the referral. What is the patient's primary respite need is where the referrer can communicate. This person needs a vision voucher. This person needs a colonoscopy. This person just got diagnosed with leukemia and needs to be set up with oncology. Whatever their primary medical goals are would go there. And then the rest is just some other information that's helpful for us during the screening process.
All right. Sorry. Next, I want to talk about a little bit about our respite metrics. Before I do that, I just wanted to share that we got to present our program at the National Healthcare for the Homeless Conference in May in Phoenix, where programs from all over the country um, come and learn from each other. And so it's really neat to have our program spotlighted. And one thing that I had taken for granted and didn't realize as we were sharing our program was how quickly we were able to operationalize and stabilize over the last 2.5 years and continue to grow. Um, and, people would talk about, well, we don't know how to get our patients to a primary care provider or how to set up appointments or how to even set up a referral system that's on the computer or get people eligibility. And as we were thinking about it, we were like, I think one thing that was so cool about this program that I continue to feel grateful for is when we started, we already had a very robust case management team that really showed us how to really do like intensive case management. We already had a rock star eligibility team that was already really working with our folks. So it's very natural to bring them into a respite setting. We already had our transportation program set up. We had this amazing informatics team that helped us set up our red cap. So I just wanted to give them a shout out and also share that like this doesn't happen overnight. And as we look to other programs in the country, they were also really impressed by how quickly we grew. And another thing I'm very grateful for is just the relationships we have in our community. With a new entry, with the city, with Urban Alchemy, that we were able to come together and speak of this need and share, them say, well, we can work with you and give you some beds here. And this is, and so it's just been really great. And so as I look at this metrics, this is another amazing thing that I used to do things on Excel or like count up by numbers and we had this amazing team put together a dashboard for us, which would have taken me a million years. So I am so grateful to share some of these numbers that can speak to how we've served people over the last 2.5 years. So the first slide I'll show you is just the referrals. If you look at the red box, the first column is our first fiscal year, 2023, and then how many referrals we got in 2024. You can see we had 235 referrals, and then this next red box is 360 referrals, and that's still with about another month and a half to go. So we are growing pretty quickly. All this to say is, I know Laura shared with you the respite criteria. We want to take as many patients as we can. We are limited by our number of beds we have, but we continue to want to hear about the need. So we hear from community members like, how do we make a referral? How do we get into the respite program? Please reach out to us. We want to hear where the needs are. Right now, we have focused on certain areas, but I think we want to continue to grow and figure out who are missing and where the gaps are. And then you can see the orange bars are how many people we accept, how many people end up canceling the referral. Maybe they have other options. Maybe they're not. Maybe they decline to come to us, and then how many are denied, usually because they're too acute for our setting. And then that little box on the right kind of shows you the breakdown of where the referrals are coming. Most of our referrals are coming right now from Central Health, from our various programs that we have, transitions of care, our inpatient case managers. Our second most referring source is Ascension Seton. And then our third is from our community care partners with their homeless healthcare team. Next, I want to share with you a little bit about our admissions. This shows you how many patients we have approved over the last 2 years have come into our program. You can see it by quarter on the bottom panel, and then on the top, like cumulative. So you can see it rising, and that really speaks to how many beds we've added from 5, then we add another 5, then we add another 5. And so as our capacity grows, we can serve more people. And then the next table speaks to our discharges. Um, so about let's see if so we have about 58% of our patients complete our medical respite, and people often ask, well, what is the average length of stay? For people who complete our program, it is about 6 weeks. And then we have some people who choose to leave. We call that self-discharge. And on average, people self-discharge at about 2 weeks. So I still think that's a win because they have been in our program with an opportunity to rest. And then for people who are administratively discharged, they stay about 25 days on average. And then on the column to the right, you can see where our patients go. So for patients who are complete our program, about 6% will go into permanent housing, 11% will go to transitional housing, 9% we will be able to connect with family or friends, and then 9% will be able to connect to our board and care called Fresh Start. And then about 25% will go back to the streets, and then another 25% will go to a shelter bed that we are able to get them. The next slide looks at the demographics. So the pie graph shows the breakdown of male to female. There is a predominance of males. Then you can see the average age with most individuals falling in the 50s. And then the bottom graph looks at the breakdown of by race and ethnicity. And then the next slide, a lot of times people ask, well, who's coming to respite? What are their most common diagnoses? I'd say the biggest one, it sort of makes sense. People that we are very vulnerable on the streets are skin infections and wounds. We know if they're not in a safe, clean place, those wounds will open up, maybe spread to the blood or to the bone and get much worse, and then maybe require an amputation, which is not something we want for them. The second most common is fractures. We see a lot of fractures, either, yeah, assault, being hit by a car, things like that. Another common diagnosis is heart failure. And then we also have a fair amount of cancer patients that come to us. With that being said, that is the primary diagnosis. We know that over, 60% of our patients have concurring mental health diagnoses, mental health conditions, and then over 70 to 75% of our patients also have substance use disorder. And then this last slide talks about some of the services received. I just wanted to kind of show you all the different things that patients can get while they're in respite, where they want to, we help them get to their medical appointments with transportation set up. We help them get ID cards, work on housing, food stamps, social security, establishing them with the PCP. So a lot of great things can happen while you're at respite. So that was a lot of graphs and numbers. So I'm going to turn it over to Laura to share with you some patient stories.
So yeah, first patient story. This is Don, and also Don's Blue Jay. His name is Bluge, and Don trained him how to sit on his foot. Um, Don came to us with hepatocellular carcinoma in 2023. While he was in respite, we tried several months of immunotherapy and procedures, but unfortunately, his cancer progressed and metastasized. And Don ultimately decided that his wish was to go home to his mother's house in Baton Rouge. And we were able to get him there, and through our friends at Austin Palliative, connect him with home hospice at his mother's house. And then that's where he passed, surrounded by family. And before he went to Baton Rouge, we had a going home party for him where we had his favorite um, Popeye's apple pie. That's one more thing. Yeah.
I just wanted to share that, a medical journey doesn't always lead to perfect health. I feel like for us, a lot of it is accompaniment on their journey. There's this one quote that says that we're all walking each other home at the end of the day. And I think this was very special because, first of all, he was a shining light to our team. He often cheered us up when we were feeling down about things. He always had a warm smile for the other individuals staying at a new entry. And I remember before he went home to Louisiana, I had a chance to call his mom, and as a mom to mom, we had an opportunity to talk about his journey and thank her for raising such a wonderful son. And she was excited to make some home cooking for him when he got home. And so I think this reminds me that sometimes like a health journey isn't about like medication and the perfect A1C and, all of these things that we often measure ourselves with. Sometimes it is the compassion that we can give an individual, making sure that they have every opportunity to, be on, have the best health that they need. And then letting them have the choice in what they want. And so before he left, we also gave him a picture of our team and a little blue jay to remember us by, which he really loved.
Yeah, Don was a very therapeutic presence. He just always went to group therapy and gave every single person in group therapy a pep talk. He was a wonderful person. Our next patient is Greg. He is a Navy veteran. He came to us last year with right eye basal cell carcinoma and a large fungating tumor. He also had squamous cell carcinoma on his lips. And since coming to Respite, he's gotten a Mohs procedure to treat the cancer on his lip. And he also underwent several months of chemo and procedures and resections. And now, oncologically, he's in a really good place. Um, he was also helped by our awesome resource and eligibility team to get Social Security. And so now he's getting ready to move back to the country where he's from, where he likes to hang out with horses and his sister and go fly fishing. So he's doing great.
To add my 2 cents as usual. So yeah, Greg is very special to us. And another thing I realize is sometimes we're the family that they don't have for some of their, to fill in. And it reminded me this past week, Greg had a close family member pass away, and he had to leave pretty suddenly. And the first, he immediately called Laura. I feel like Laura's been a very supportive person in his life. And so when he had his surgery, our team visited him in the hospital. And so I think, again, I'm talking about the accompaniment of someone's health journey has been so special for us. I also just want to share this other gentleman in the picture. That is his roommate. This
And bestie.
This individual came to medical respite for an infection. And while he was with us, we said, well, hey, you need a colonoscopy. It's time. He said, okay, I will. And he got it done. Unfortunately, he was diagnosed with early colon cancer. And so while he was in our program, he came in for an infection, but also was diagnosed with colon cancer. And also, we were able to get him treatment for that. And he underwent surgery and was able to get it out. But what was really interesting and neat was they were both in the hospital at the same time for different surgeries and decided to visit each other while they were there. And we just thought that was so sweet. I know when they were roommates, one was annoyed that the other one was not as clean, but at the end of the day, they were really there for each other, sharing each other's cancer journey and supporting each other.
This is our last story. This is Pedro. He came to us after getting a left transradial amputation. He had delayed wound healing because of poorly controlled diabetes. And we were able to connect him with a Freestyle Libre sensor, which is a lot easier for him to manage his um, glucose with because he only had one hand. Um, so one thing about Pedro was he was almost all the way blind when he came to the program, and we got him cataract surgery, and it was a really sweet experience to see him see for the first time. He was just giggling for like an hour about being able to see. And that's him in his or in my cool shades. Um, yeah. So Pedro is also a really sweet person. He loves Radio Romantica.
I'm gonna add so the picture on the left was when he first came to us, and he was a day laborer and didn't have time to take care of his needs and had an infection on his hand that just he overlooked, just didn't have time. And that infection spread to the bone and unfortunately required an amputation. Many individuals who get amputations often are discharged from the hospital with like, goodbye, good luck, here are your appointments, good luck with that. And it takes a lot of time to get a prosthesis, get it fitted, start to learn how to work with it. And that's something I didn't even know until we got to take care of Pedro. And so bringing him into our program the first time, helping him navigate with his waiting for the prosthesis, getting the prosthesis, and then getting it fitted, helping him learn how to use it. It doesn't happen quickly. It actually took about 6 months. But that was we were committed to that and wanted to help him through that journey. And as Laura said, the second time he came to our program, he got cataract surgery, and as Laura said, that was wonderful to help him and be able to get these surgeries done. Again, very hard when you're on the streets and not able to coordinate that care, the all the appointments leading to it, and then all the things post-op. And I love that picture because yeah, those are Laura's sunglasses, and he didn't have any after surgery, so she gladly let him borrow hers. So love that picture. Want to talk about that, or you want me to? Okay. So yeah, I just highlight all the benefits that I've kind of talked about during our presentation: the opportunity for health education and reinforcement, medication teaching, and being able to monitor someone and make sure that they're comfortable taking the medication, the ability to we see the improved mobility with the physical therapy they get on site, um, being able to see their wounds getting healed and the closure, being able to make referrals to specialties and other services, getting outpatient surgeries completed. Oftentimes they're elective and not critical like cataract surgery, but very critical to the people who are dealing with these issues. And then preventative care, like that patient who was able to get his colonoscopy. So many things about medical respite. Really, just the time, having a team, and a place that's safe to be in while you're coordinating everything.
Another one that comes up is dental care. That that comes up quite a bit, that people will have a dental infection or some kind of dental problem that causes a lot of pain, and then that's pretty easily resolved with a dentist visit. And some people just need help coordinating that. And then same thing with a vision voucher. A lot of people come to the um, program severely visually impaired, and then they're able to access glasses, and it's kind of a game changer.
All right. All right. So, in summary, we were so excited to share with you our program. As you can see, we're very passionate about it. We're very grateful that this program exists in our community, and just so happy to be a part of this program. You can see that it gives individuals a chance to heal physically, rest in a safe environment, and have time to address their concerns and their priorities that they have. It provides time to coordinate healthcare and housing needs. And lastly, it gives people an opportunity to make meaningful progress toward their housing goals and even resolve homelessness whenever possible. So, with that, thank you so much for joining us today, and we will take some questions.
All right. Thank you all again so much for this wonderful presentation. We do have 20 minutes for questions. So we have a couple of questions in the chat. If you'd like to raise your hand, I can unmute you. But I'll take the ones in the chat first. Sonia Burns asked, are you tracking how many people you have to turn away based on them not meeting the list of criteria?
Yes, we all the referrals are tracked. We track who doesn't choose to come, and then who gets declined because maybe they're not meeting criteria. And that is a great question. What we learned in the very beginning were people were not choosing to come because they had pets. And so we realized we need to have a place where pets might be available, where they could bring them in. And so that's when we partnered with Marshalling Yard. Um, we heard that we needed more beds for people who weren't ready to address their substance use disorder. And so maybe not being in a residential treatment facility would be best for some individuals who still had very high medical needs. So, yes, we are tracking those needs and wanting to understand where are the gaps, who are we not serving, and continuing to improve on our program.
The next question is from Jesse Dalton. The recidivism rates of readmission are in strong support of the efficacy of this program. Question one, is there a plan to expand your staff and services? Then question two, are there other cities that have decriminalized homelessness that have similar programs to medical respite, to your knowledge?
That's a great question, and I forgot to mention in my presentation. Yes, we recognize the need, and often people tell me or ask me, how many medical respite beds do we need in Austin? And that's a really hard number. I think that we can look to how many people are in the hospital who are experiencing homelessness, how many people are in our community. But I also think, you know, w- there are different levels of need. Some need a place for their colonoscopy. Some need a place after they have a broken leg or a heart attack. Some people need a place because they want to consider sobriety and they need a place to be as they make that decision. So there's a lot of different levels of need, and as we grow, we want to think what are the locations where we can serve more higher acuity needs, more lower acuity needs, and everything in between. So I'm excited to say that we will be expanding our program to hope to bring on a freestanding site. And we are looking at some different locations in our community. One is downtown at the CEC that's located on 15th and I-35. That is a building we're considering. And then, as many of you may know, Central Health did purchase some buildings on 183 in Cameron that we are looking to bring on a medical respite onto one of those buildings in the near future. So we're learning a lot as we go. We're learning a lot from different cities. So thank you for bringing that up. We had a chance to visit Phoenix, which has one of the best programs in the country. They have now 3 medical respite programs. Uh, Different buildings of 50 each, and learning about some of their policies and programs, and also learning about how we can set people up for success when they leave. We don't want it to be another revolving door like a hospital or an ER. We want to change that trajectory for them and start to think about how do we ensure that someone who leaves medical respite doesn't have to be hospitalized again, doesn't have the same challenges, and that's going to take the whole community. We that doesn't, I and that's something I'm excited about is bringing the whole community together to think about how can we, provide more housing downstream, more case management, all the different services that someone might need when they leave medical respite. Because we know that it's still, things are still needed in their lives, and so thinking about what that looks like. So there are a lot of different cities that we've reached out to. We met with LA's program. As I mentioned, this National Healthcare for the Homeless Conference is a wonderful opportunity where we learn from other programs of what's happened, what they're doing, and things that we can learn from. So lots of great collaboration across the country. Medical respite is not a new idea. There are over 100 programs across the country. They look different in every city based on what the community has. And so that's something that we will continue to look at. So thank you for that question.
All right, next question. We have Ricardo Garay. Have city council and or state legislators been made aware of the extraordinary need and the specific amount of funds that would be needed to provide adequate care?
Uh, yeah, medical respite is definitely gaining more momentum in our country. In fact, there are some states right now, particular states who have expanded Medicaid, where Medicaid is now paying for medical respite stays. So I'm excited to hear more about that as we understand the critical need for these services. And so we will continue to, advocate for medical respite in Austin, in Texas. But it's great to see other states and other communities really um, uh, recognizing the need such that, insurance companies are starting to pay for it. Hospitals also contribute to some of the funding in other cities. So I think that one thing I have loved seeing in our community is this is a need that we have known for a long time. And I believe that this is a need that everybody should really be rallying around. And while Central Health was the first to really bring this program to our community, I really hope and am excited to see other partners really come to the table, whether hospital partners, other housing partners, really kind of think about how can we really make this even better so that we can continue to provide services.
All right, we have a few virtual hands raised. Right before I go to that, I'm just going to read off a couple comments. Uh, Krista Signor said, incredibly grateful for the work you all are doing. Ricardo Garay said, I appreciate that these stories are being highlighted. Quantitative data is important, but human stories are key. Thank you for humanizing healthcare. And I am now asking Monica Rodriguez if you can please unmute. You should be able to click. All right, perfect. I don't know if we can hear you yet, Monica. Can you do a quick test? I'm gonna ask Ellie Grunder to unmute, just so we can make sure that it's not on our.
Hi, Audrey and Laura. Can you hear me? Okay. Hi, I'm Ellie Grunder. I actually had the pleasure of working with the two of you a little bit on the referral forum. And so it was really, I was holding back tears listening to some of the personal stories that y'all shared. I really appreciate that. And I wanted to ask, so you mentioned that 70 to 75% of your patients are dealing with substance abuse disorder. And so if you could you, and also that you're, not equipped to deal with uh, acute psychiatric patients experience acute psychiatric events. Would you mind speaking a little bit to how you approach withdrawal with these patients and also the behaviors associated with this as a program?
We rely a lot on integral care, and then also the EMS system for withdrawal medical type of reactions to substance use disorder. And then for psychiatric needs, we have great relationship with several people at Integral Care, and we bring them in. And then they also have a psych respite that's more appropriate than our respite for people with acute psychiatric needs.
Yeah, I'll add in terms of substance use disorder, there are individuals, we have the whole spectrum, individuals who come in saying, I want to work on this. This has been something I've been really wanting to work on and I'm ready. And then the other side of the spectrum is I'm not sure that I'm not really, I don't think it's a problem right now for me, and everything in between. And so for those individuals who are ready, we want to be on it. We were like, okay, it's go time. Let's do this. And so one of our sites, a new entry, is a residential treatment facility, which I think is very conducive to individuals who want to address those needs. They have groups. They provide a lot of help and services in that regard. We also are very fortunate to partner with Community Care's MAT program. Dr. Weems and his wonderful team have started to do some rounds on site with our patients, meeting them either on site at our respite program or open to us referring into their program at Community Care. So that has been so great. I think at least, would you say half of them are patients? Maybe. Yeah, I think at least half will be interested and want to meet with the Dr. Weems and his team and want to consider some medications or counseling, whatever they think is appropriate for their treatment plan. And so that's been great. I think there's still some room. We're hoping to hire peer support specialists for our team to continue to support some of those needs and then help navigate that. Uh, yeah, those needs there. In terms of mental health, again, wide range of needs. And there's people who want counseling and therapy, and we can refer them to integral care. Also, community care has wonderful behavioral health consultants, counselors that we refer into. We also refer to their psychiatrists um, that they have at community care. So we have a lot of different options that we're very fortunate to have. When we've learned from other programs in the in the country, they don't always have those uh, those easier referral workflows that we have, and so we can leverage off some of those relationships with community care. And then we at Central Health are now building out some of our psychiatric services as well. So more to come on that, but we're hoping to bring some of that into our program as well.
A new entry's also been really amazing at letting us bridge to treatment there. So if somebody has a medical need, for example, we had somebody with skin cancer, treated the skin cancer, and then that person was ready to start working on substance use disorder concerns, bridged to the a new entry residential treatment program, and then completed the program over several months.
All right, a question from Sonia Burns. Are you connected with a SOAR specialist? Also, did you already say average cost of day/person in respite? I realize everyone is needing different supports and or tests, etc. But just thinking average in terms of Ricardo's question about legislator for funding purposes.
Yeah, so thank you. SOAR specialists are a huge need in our community, and we're very lucky to have a wonderful eligibility team at Central Health that does then connect to our patients at Respite. And I wish I had the number of our success rate, but I know that our eligibility team has a 90%. Wow. Because our patients are already coming in with high medical needs. I mean, I think, as someone who's been doing a lot of SOAR, I call them my slam dunk diagnoses: heart failure with an ejection fraction less than 35%, all of these things that we know if they just had the right connect resources, they could get Social Security income. And so having individuals come into our program, I have loved having that for them with our eligibility resource specialist to be able to connect them, help them apply for SOAR, and then get them on track to get that benefit.
All right, a question. This is a question from Joshua Collier. A question addressing patient-centered continuity of care. How are you addressing the challenge of completing efficient, secure electronic transfer of records between central health, community care, and outside providers like Ascension Seton, specialists, etc.?
That's a great question. Well, I would say that right now, one thing that's very helpful is Central Health and Community Care share an Epic record. And so, with Community Care's wonderful and robust healthcare for the homeless team, which many of our patients either will connect to or are already a part of, we can see some of those records and just sort of be part of that continuum of care. And so, we can see Community Care's records, which is great. I, as a provider, have access to Seton records, so that's very helpful as well. Um, Looking at hospital records, their ER notes, and I think I appreciate that question because care is can be so fragmented, and that is one of the biggest barriers I think in any community. And so really thinking about how can we improve that so we're not duplicating efforts, so that an individual doesn't have to repeat the same often traumatizing story over and over. That ability to share notes and collaborate has is really important. And so right now with Central Health and working closely with community care, with some of their MAT team, their psychiatrists, BHC, their mobile teams. We're working very closely with them, and also with their specialists and our specialists. I think it continues to be a challenge with some of the outside specialists, and I think that's where I think we really enjoy making friends and meeting people in our community, and really trying to improve some of the relationships. And then starting to build some of the infrastructure to share those records.
And Joshua Collier just responded to that, said, "Thank you so much for your response," and to the moderator for asking the question. Thank you, Joshua. I think we are right at time. I do not see any other virtual hands raised or any questions in the chat. As a reminder, y'all do have our contact information. We will be sending a follow-up email with a recorded YouTube link for the English and the Spanish presentations. And so I will put the link of our YouTube channel in the chat in case you have any questions. Oh, we do have one more question. Do we have time? This one is in Spanish. So I will translate in English. Marcela Garcia said, "I have a question about the applying aplicación de crédito. ¿Es para todos los pacientes o solo para algunas personas? Escala." She's wondering if the credit application is for all of the patients or only for a certain amount of people. Is it different than um, the like the community care card of what is it, the la tarjeta de escala of sliding fee scale? My apologies, I lost the word. Yeah, so does this application, this credit application, I'm not sure if I understand the question.
If somebody is a sliding fee scale and they're eligible for MAP 0, we can help get them over to MAP 0 so that they are eligible. So if they're unsheltered and they meet all of their income requirements for MAP homeless, then yeah, we can facilitate that process to make them eligible. We won't deny them because they didn't meet criteria for that reason if they're eligible.
Perfect, thank you. Did that answer your question, Marcela? Perfect, thank you for guiding me through that one. Well, thank you again, everyone, so much for joining us. Thank you so much to our wonderful presenters and for the amazing work you do for all of our community members. Thank you for joining us, and we'll see y'all in a couple months for our next Lunch and Learn.